So good afternoon, everybody. I think we'll get started. It's just after 1 o'clock. Welcome, everybody. My name's Nick Holding. I'm an improvement manager with the Emergency Care Improvement Support Team, and delighted to be able to welcome you today to our first in the series of our national learn events for Recondition the Nation activities that we are putting on at the moment. Just to let you know, we are recording, and we will make the recording available to everybody on this call, but also we'll share it out via social media, and you can share that link as well with colleagues who weren't necessarily always able to make it today. If you're joining the call, if you're not on mute already, please mute if you're not speaking, and that gives our speakers the chance to talk to you undisturbed. Today's events running fortnightly from today, leading up to May. We've got a series of really interesting keynote speakers lined up already. There's a few gaps still to fill, so we'll keep you informed about as we invite more people or get more people confirmed. And really interesting to hear about all the great work that's happened as well from organisations across the country. We are joined today by Dr. Amit Arora, who's going to deliver our keynote session today, and then Karon, Sam, and Sarah from QE Hospital in King's Lynn. So great to hear the work that they're doing. Just to say that the reconditioning games kicked off in early November, and already we've awarded over 260 medals right across the country. This really stands on the shoulders of the excellent work that the East of England did with their winter deconditioning games last year, and of course the phenomenal work that Brian Dowland has led over the previous years around PJ paralysis. And our aim here really is to re-energise the amazing work that often is going on around patient reconditioning to avoid patient harm from deconditioning. The thing to remember, the always want to stress, is behind every medal there's a patient or a member of staff that's just having some care or some enthusiasm which is making their life better as we look to reduce deconditioning and help overall to help recondition the nation as part of the games. So to kick us off, I'm going to throw the mic over to Dr. Arora, who's going to lead us in, and then we'll hear from Karon, Sam, and Sarah from King's Lynn. Amit, over to you, sir.
Thank you, Nick. Let me try and share the slides if I can. Can you see the slides? Nope.
Because Hannah then sent to her, she said, "Oh, I have the things here. Are you ready?
Yes, I can. Yeah.
Would you be ready to open it?" And Hannah.
Nick, can you see the slides? Hello?
I can see your desktop, Amit, but not your slides. So you just looks like you're sharing your team screen.
Now?
That's better. Yeah, if you can just put it on slide share, that'll be amazing.
Sure, what's going on here? But anyway, you can still see the slides, yeah?
Yeah, we can see them, Amit. Yeah, you crack on, mate.
Okay, right. So thank you very much for joining our first event in the National Learning Series on Reconditioning the Nation. So as you know, and Nick has mentioned, this program was started on the 1st of November, and a variety of individuals, teams, organizations are taking part in this work. In this series, we are bringing in one key speaker and 2 or 3 different individuals from variety of teams who are doing some great innovative work, which I think is going to be exemplar and leading the light in encouraging other teams to actually do some more innovative stuff as well as replicate what is already being done. So I think by the sheer nature of the attendance here, it is clear that you will all know what deconditioning is. So, but in summary, deconditioning is the loss of physical, functional, and psychological function due to inactivity. Reconditioning is just the opposite, like the repair shop you might have seen on TV. Let us go through what the evidence tells us. We know that hospitalized older people are some 60 times more likely to develop disability in activities of daily living than those who are not hospitalized. Half of these patients experience functional decline between admission and discharge. We know that many frail older people spend only 5% of the time away from the bed or chair. And for many, it could mean just 6 or 60 steps in one full day, 24 hours. This leads to physiological changes in the body, which reduces muscle mass, blood flow, lung oxygenation, changes in the skin, loss of confidence, loss of continence, loss of dignity, and loss of independence. Why does that happen? The muscle mass and the strength reduces by 2 to 5% in the first 24 hours. So while your patient is still lying on the trolley or a bed in a ED or a admissions unit, they are losing muscle. And for many, within the first 7 days, they might have lost up to 10% of their muscle mass. And the same kind of changes, without going into the proportions, same kind of changes happen in other body systems as well. And I think we have already, over the years of clinical work on the wards or in care homes, we have kind of seen that how this reduction in the muscle mass, how this reduction in the blood flow takes its toll. And we have seen how the quality of life can be impacted. And being sick and in hospital has got consequences. Some of them are the traditional ones about which we know, that is, infections like C. diff and MRSA, and thromboembolic events like DVTs and PEs, and so on. But until recently, we did not know much about deconditioning, and the evidence has only started to emerge more so in the last 5 to 7 years. Nevertheless, it is really, really important. Let me introduce you to Mrs. B. Now, this is a real story. On your left, you see Mrs. B at home playing with her dog sitting on her settee, in her own clothes, in her own shoes. Despite her age and frailty, she appears content, independent, happy, and enjoying. A minor urinary tract infection brought her to the hospital, and Mrs. B was converted into a 90-year-old lady lying in bed with a bruise on her arm, looking more frail, in a gown she probably doesn't like, and dependent. What came next was even worse. A vicious cycle of delayed discharges started, and then we spent time and effort in rehabbing her because we deconditioned her in the first place. And a cycle of ward moves and a transition bed and an assessment bed and rehab bed and readmissions, all that started. This is real, and we've all seen it happen in our wards or in our care home patients. The key thing is this is avoidable, this is preventable. In fact, deconditioning is probably the most underdiagnosed, undertreated condition in hospitalized older people with frailty. Let us see what do our patients say about wards, about activity. I'm bored. I've hardly walked. Not sure if I can. Not sure if the staff has time to take me to the toilet. And this is the most amazing one. I will get better when I get home. Goodness me, what are we actually doing? Let us see what the data tells us. People over 70 make 13.5% of the population. They make 22% of ED attendances, and they have 66% bed usage in hospitals. Very disproportionate. Part of this is the deconditioning that happens in the hospitals. And this data alone shows that if we get this right for frail older people, we will get it right for everyone who uses the NHS. We ask ourselves a question on our wards. Is the patient safe for discharge? And I sometimes feel if the right question to ask should be, is the patient safe for admission? Now that may be a bit tricky, but I think when we encounter patients in care homes and paramedics and ambulances in emergency departments, if we change that thinking, if we change that language, that is there any way I can actually treat this person at home or in their care homes or with some support from the community? And this is not to say that patients should not be admitted to hospitals. Hospitals are surely the right place when they really need to, when things cannot be managed at home, when treatments cannot be carried out at home. But the level of dependency a lot of patients get when they're in hospitals is heartbreaking. And I think we do need to do something about this. You will all know what do our staff say about this. A lot of staff come to work, and when they go back on a daily basis, they go back with a moral injury, thinking, I haven't done my job properly. I could have done better. This is despite the fact that they have actually done a great job. This is despite the fact that they have done more than what they could have. And they have given their level best under the circumstances, but yet they feel, oh, maybe I could have done a bit more. And there will be a lot of reasons behind this. But there is a truth that a lot of our staff, doctors, nurses, therapists, carers, and not just this staff, but the staff who works in care homes, in domiciliary care agencies, as well as others, including a lot of managers, secretaries, kitchen ladies, receptionists, and you name it, most of them will have a degree of that moral injury, saying, well, oh, maybe I could have done a bit more, maybe I could have done a bit better, despite the fact that they've actually done everything that they could have done. One question I'm frequently asked is, should we consider deconditioning as a harm event? Now, this isn't about individual harm events, although there will be some, but it is about changing the culture and changing the language. And perhaps rather than opening a new datex industry, consider adding a question in the datex. Could deconditioning have contributed to this adverse event? That generates awareness without making a new paper industry. And every time we introduce a paper, we take the doctor or the nurse away from the patient. Adding deconditioning in medical, nursing, and pharmacy schools curriculum. This is work which is already in progress. Adding deconditioning in trust inductions and presented the trust boards in the form of a patient story. That is really, really powerful. Contact your hospital charity, for example, if they can help with some equipment and things like that. And these are practical things that, as responsible senior members of our teams, we can probably influence. But all this needs a culture change. It is about hearts, heads, and hands, as my dear friend Brian Dolan says. This change is happening. Slowly but surely, this change is happening. It will take some time. It will also take reframing of our own thinking about change in our language, change from false prevention to safer mobility, as our Chief Nurse Anne Marie Riley has just launched Safer Mobility Ambitions. Changing the language from reducing length of stay to giving patients back the time. Change from days in hospital to days away from home. Or maybe even change from hospital in the home to there is no ward like home. And change in the language from deconditioning to reconditioning. And that is why we've kind of started this program to recondition the nation. There are things that we will need to do when patients are in hospitals and in care homes, when they're living alone or with someone but dependent on carers to mobilize and so on. There are simple steps we can take to reduce that deconditioning that happens. One of the other issues is, can we actually provide rehabilitation for every patient? Let's go through some data. So there are 1 million patients aged above 75 which are admitted annually to acute hospitals in England alone. 200,000 of these are severely frail. And this frail population is likely to increase by 148% in the next 12 years by 2035. There are 400,000 people in care homes, and many, many, many more live alone with support from carers and minimally mobile. Only 10% of care homes have physiotherapy services provided within their own homes, and there are only a total of 28,000 physios and 46,000 occupational therapists. So there is a shortage of staff. What do we do? And that's why I think deconditioning prevention becomes everyone's business. A therapist, a doctor, a nurse, a porter, a pharmacist, a carer, us all, executives, and everyone else. Public, school-going children, everybody. In the Reconditioning to Nation program, there are two key purposes. One is to prevent deconditioning and improve patient outcomes. And two is to bring joy in staff's day-to-day work and improve staff morale. And we all know that happy staff delivers better outcomes. So there is a win-win for both patients and staff. Of course, there are other things about reducing length of stay and supporting people where they can continue their recovery at home via the discharge to assist programs and development of the alternative pathways that are currently happening. Whether it is virtual wards, whether it is same-day emergency care, whether it is urgent community responses, or whether it is enhanced health in care homes, and so on. But what I would like to say is that the purpose of the mission to recondition the nation relates to two key outcomes. One, improving patient outcomes through deconditioning prevention, and two, improving staff morale by introducing joy, introducing some fun in their day-to-day work. So, colleagues, these are games for everyone. There are certificates, medals, badges for everyone, whether you are an executive, whether you are medic, nurse, secretary, school, council, care home, dome care team, paramedic, primary care, social care, perioperative care, awaiting elective care, outpatients, and so on and so on. There are 3 different medal categories and 3 types of medals: bronze, silver, and gold. And we are thinking of introducing a platinum award as well at the moment. So there are multiple opportunities. Whether you work in whichever setting, there are ways and means you can actually participate. Let us see what other people are doing and how this is changing the nation. So multiple teams have introduced chair-based and bay-based exercises. I recently read a few days ago somebody has introduced bed-based dancing. Teams have also done static pedal bikes on wards or in care homes and when undergoing dialysis, for example, to build strength. Others have played winter Wimbledon or bed dances or virtual walk to the seafront. Different approaches using staff from therapy, ward, care home staff, as well as volunteers have supported these various projects. These initiatives have made a huge difference to patients, service users, and residents. They've enjoyed the music, the social interaction. It helped relieve boredom and made people feel happy and better in themselves. There was also some evidence that it helped to improve appetite, fluid intake, sleep pattern, and possibly reduce falls or even length of stay, something we are regularly measured upon. In another place, 400 miles were cycled by patients, 10,000 miles were staff mileage. Our own team is also doing a walk to the moon and back and recording the steps via an app. So let us see whether we can actually achieve that. Even if we don't achieve the mileage, I think we would have done something great. Last year, as Nick said, when we did this in the east of England, we awarded 178 medals for various categories. The medals are back. The games are back. They are bigger and better and are across the country now. And we have already awarded over 250 medals now. I ask you to join, do something different. Applying for these medals is very simple. There are no large forms to fill. You get a certificate straight away and badges will follow in post later. Print your certificates, post them on Twitter or your work website. If you're keen, we can support you in writing a case study on what you've already done, and we can get that published and spread the great work you're doing. So, colleagues, improve patient outcomes, reduce deconditioning, bring joy to the work the staff do, and prevent that avoidable moral injury to our staff and teams. But before I finish, there is a reflective task. What will you do differently when you go and see your next patient? Simple ask, simple task. Have a think. What contribution can you make to prevent deconditioning when you see your next patient? There are some examples here, which you can develop your own. So, colleagues, one of the amazing things about this work is that I meet amazingly inspirational and innovative colleagues who are driven by their excellent values and go above and beyond the call of duty and their jobs. We are very lucky and grateful to have 3 wonderful colleagues who have been doing some great work to recondition the nation, and they have been spreading the message far and wide, loud and clear. Let us hear from them regarding the excellent work they are doing, the know-how of this, and the challenges they face and the satisfaction they get. Let me hand back to Nick to welcome Sam, Karon, and Sarah. Thank you, Nick.
Amit, thank you very much for that. Inspirational as usual. I think the simplicity of the message is the key bit that hopefully most people will take away from this. This is not this doesn't require big project plans, and it doesn't require huge action plans. This is about keeping it simple. And on that note, I think really delighted to hear from the guys from QEH in Kings Lynn about the work that they're doing. I've heard a little bit before. We recorded a podcast, and some of you may have heard that podcast before, but really keen for them to share a bit more about the work that they do, and particularly around some of the staff wellbeing work as well. So, Karon, are you sharing your slides today, or is somebody else got control of the?
Yeah, we're just working on it, Nick. I think I'm going to have as much luck as Amit did. Thank you very much for inviting us to join you guys today, and thank you, Amit, for the very warm welcome. My name's Karon Strong. I'm head of nursing for the Division of Medicine at the Queen Elizabeth Hospital here in Kings Lynn. And today I've brought along with me Sam Jude, one of my ward managers on Feltwell Ward, and Sarah Champion, one of my ward managers on West Dereham Ward, that a lot of you will have seen on Twitter, doing some wonderful stuff to help the process of reconditioning the nation. Before I hand over to them, we're exceptionally lucky here at the QE in Kings Lynn. We have got our executive directors and the board completely behind us in everything that we're doing, to make a difference to all our patients and staff. This isn't something that is going away for us here at the QE. So, as Amit rightly said, we are all working to recondition our patients at the moment, but the QE's task is that we don't decondition any patients any further, and we continue to keep people up and mobile. Even when the games end, this becomes business as usual. But the real important bit is the two champions that I've brought with me today, Sam and Sarah, who have worked tirelessly with their teams to really make a difference to our patients here at the QE. And I'm going to hand over to Sarah first and let Sarah tell you all about some of the really good stuff that they've been doing. Sarah.
Lovely. Thanks, Karon. Hi, everybody. My name's Sarah Champion, as Karon said, and I run one of the acute frailty units here at the Queen Elizabeth Hospital in Kings Lynn. So over the past few months, we've been doing some extensive work with our patients' relatives, and the team of staff that we have. That's a multidisciplinary team approach. So that is from our housekeepers, HCAs, patient support workers, all the way to physios and OTs. So it really has been a really big team effort to get this off of the ground, and we have done some really brilliant things for our patients, and we've seen the benefits, and so have the staff. So the impact of this has been quite widely spread. So I'm going to discuss some of the things that we have been doing here, and the reasons we're doing them are obvious. So in frailty, it's one of the biggest areas of deconditioning within our patient groups in an acute hospital trust. So it's really important for us. It's our bread and butter. So the things that we have been doing that have made such great patient impacts and real improvements are, we had a patient, for example, that was a frame +2, really disengaged, eating was a problem, and so we set an activity planner. We have done things like the FIFA World Cup event, where we would be doing like flag decorating and allowing them to place the flags around our day room. We got bike machines out, step pedals, and we did a game of bowling where even our patients that were bedbound or in chairs could throw a beanbag or a ball towards the bowls, and really got some engagement between our patients as well, because some patients aren't leaving as quickly as others. So it really generated a neighbourly atmosphere for our patients. We've done birthday parties, we've done a carol concert at Christmas. That's where our patients' relatives were invited in as well, and our patients were dancing with their families, and these are things that they wouldn't usually do in an acute trust. why not? We have done everything to engage our patients. And this lady now, you know, her mood has raised. She is a frame +1, even a handhold at times. So we have seen really significant impact and improvement with the things that we're doing, which has really impacted the team as well, because they're seeing the improvements in our patients. Reduction of anxiety from our families, because the families are familiar with the opportunities that their relatives have got, which is so important, patient and family engagement. It has really brought up staff morale over periods of you know, difficulty within acute care. We have done crosswords, chair yoga. The other day we had a YouTube chair yoga on with pom-poms in the bay. We're able to do knitting. Lots of my staff have facilitated kind of afternoon teas and invited family members in to lift up nutrition, hydration. So the whole impact of deconditioning on our patients is massive, and it's every element of our body. We're looking at lungs, cardiovascular, diet and nutrition, and amongst frailty and healing, all of those things are as equally as important as the other. We have done things to be inclusive. So we've had a multi-faith service in our day room. We have had a singer come. We've had art and crafts for people that don't celebrate Christmas, for example, but they do celebrate New Year. So we've tried to be quite diverse in everything that we're doing as well, and inclusive, because ultimately that is our plan. The disengagement in our patient group is really quite high, and that's multifactorial. So that's age, condition, coming in acutely unwell, frailty. So trying to engage those patients. We've got an activity planner, so we take this round. I've got a patient support worker here, which I'm really pleased that we were able to recruit, and they're showing our patients, you know, the things that they maybe would like. We've done we were watching Mary Poppins the other day, so we've brought the West End and Broadway into our day room, and we've got a patient in particular that really loves that, and it really reduces her agitation. So there's so many things that we're trying to do to be inclusive and really raise the profile between the staff as well. I must say our wider colleagues, our occupational therapists and physiotherapists have really helped with this. They really launched a programme for us here for the FIFA World Cup event, and we had a patient in their bed space that was brought in and could watch the World Cup. So, you know, really fab work that's going on here on West Earham Ward, and you know, within our wider trust, and we're able to share that and try and encourage each other with new ideas. So I'm going to hand over to Sam now, and Sam will talk to you about what he's been doing over on Fetwell.
Thank you, Sarah. Am I audible? Yeah, so yeah, thank you. Again, a massive thank you to Karon and Sarah, and you know, for this opportunity. Also the ESIS team, Nick, Dr. Arora, Debbie, and you know, for the opportunity that you know, we have been given to share all the brilliant work we have been doing at you know, Team QEH. My name is Samuel Jude. I am the charge nurse on Feltwell ward. So Feltwell ward at QEH is the post-acute care ward, which is basically you know, patients who are medically fit, who need to undergo you know, complex discharge planning, are then sent over to us, so that that next phase of their journey back to getting them to the right place you know, takes place. So yeah, I have been there, and my team again very passionate about you know, this reconditioning games. It's only that we keep thinking, how did it ever you know, sort of end in the first place last year when it started, because this is such an important thing for us and for our patients, it has been a very sort of transformational change for us within the teams, and you know, we have adopted newer ways of working, which has actually led to positively you know, impacting patient experience, and you know, the way staff deliver care as well. It has been, it has led to changes in, the way our staff, approach patient care with an aim to, just help with reconditioning the patient. So changes in attitudes, beliefs, a radical change. So all positively affecting and impacting patient experience. So I just wanted to kind of share some of our, some of our experiences with reconditioning games, or what we call as Let's Get Moving campaign at QEH. And since it's a learning event, I wanted to share some of the bits, what we have sort of learned as we have, gone along. This is almost the third month, and we sort of we wanted to, again, as the games suggested, focus on two important things: the impact on patients, firstly, because this is all about patients. We are here for patients. That's what I tell my team as well. And having that positive outcome, positive patient experience, and secondly, making the workplace a happy and joyful place that focus on staff health and well-being. So some of the things we were sort of involved in, and Sarah has, brilliantly explained all the sort of practical bits that they have been doing as well. And similar to Sarah as well, we have been sort of focusing on how to reduce the length of stay, getting patients, actively mobilizing, getting them out of bed, ready for, home for lunch when it comes to discharging them. In fact, even at the we were doing really well with getting them home by noon or home for lunch. And some of the important things that has really worked for us has been our daily therapy goals, which is actually in our board rounds at 9 o'clock, identifying going through all 30 of our patients, identifying what can be done with them on that day in terms of anything. It could be a mobility target, mobilizing them, getting them dressed, making them independently function, carry out their activities of daily living, do some sort of cognitive stimulation with them, activity time in the afternoon, anything, or help them so that they can sort of encourage them to independently eat themselves. So that probably helps with again getting back to that baseline. So all that in the daily therapy goals, and that is then allocated to each and every member in the team. It could either be the therapy team, therapy staff on the ward, or the nurse or HCA healthcare assistant looking after that patient. So, and then that is then finally ticked off, and if it's not done, then we put it as a target for the next day. So that has really helped, and we have seen a huge impact, and a greater compliance with that. Things as well, like helping patients to have a shower versus having a wash at the bedside. That has massively helped. We were at an average of 2 to 3 showers in the whole ward per day, which has tremendously increased to 6 to 8 even on an average. So that has been a huge impact. And having a shower, you can also just imagine how much positively it influences. So that has been really great, and the teams have been so passionately driven to get that going. Just want to read further as well. Again, enabling them to participate in activities. I have got some pictures towards the end. Some of those bits, we have been carrying on the ward. What that has actually, how this has sort of worked for us is, just wanted to kind of, again, as a learning event, we had a clear focus, a clear strategy, and a simple process of just supporting the team through this big change, because again, it was a change in our ways of working. It was a change in culture, because historically how it happens is we have had therapy staff taking over, mobility and all of that. So it is how we get the nursing staff to take on that bit of, assessing patients for movement. So that has been huge, getting the teams on board. Mainly as well, it has been a trust-wide agenda. It has been a trust board priority, and that energy and that passion. And again, Karon is here. She is the senior SRO for this Let's Get Moving campaign trust-wide, and that passion, from that level, bringing it to the ward level and getting the teams engaged, that has hugely helped us because the trust was very driven behind getting this as core agenda for us, and that we sort of brought back to the teams. There was a lot of education and training there, involved with training the team members, again with doing this extra bits of assessments, collective leadership, and sharing that vision and purpose, and getting those shared solutions, getting ideas to come through, creating that culture of continuous improvement, and that journey, traveling with the team in that journey, in getting those creative ideas to come through. It was also about positive risk taking, in which sometimes it's about an idea comes through, let's just try it. And that was a huge impact as well. Just let's try these ideas. I had recently done my sort of QI training, quality QSER training, so that really helped as well, because getting the data, and we know that data drives improvements. So getting that data to actually understand this change, support staff through the change, and helping getting those datas and getting into meaningful information. And that has been sort of our strategy, in terms of helping us, with this Let's Get Moving campaign. There was another hugely important bit I wanted to actually focus on as well. That is investing in staff, investing in my people, and that is actually one of the greatest asset we have in the team. And that is again, like Dr. Arora said, happy staff deliver happy care, and more better care, and high quality, safe, high standards of care. And I think that is very relevant, and we have seen that as well. So that is just thinking about what makes them smile, what makes them happy in the workplace. And so our next phase from February onwards, we will be looking at well-being champions on the ward, well-being trolleys, well-being boxes, and things like positivity tree, gratitude board, all of that. So please watch this space. Again, Twitter is the place where we all share our learning, share all the great things, learn from each other. So the most important thing, I have said about the impact on our staff. Absolutely brilliant staff, are so much more engaged, more cohesive to deliver all of this for our patients. But the best thing that has come out is the impact on our patients and their families, their loved ones. So one of the examples is patient story 1, which a patient with multiple infarcts, right side hemispheric stroke, was waiting a D2A pathway. I'm sure most you're aware of the D2A discharge to assess pathway. So he was awaiting a bed in the community, but we identified him as having a potential to be worked with him, to dress him, mobilize him out of bed, give him that bit of cognitive stimulation, work with him to then aim at a D2A1 pathway, which is potentially package of care at his own home. And what better for a patient to be at their own home than anything else. So this patient, actually we worked with them for about 2 weeks, and at end of those 2 weeks we managed to get them to their own home with their family actually bridging in care. So not even starting off with community care, so it's just family starting off with actually giving them care, and then later on for carers to come in. And the joy, literally tears and joy in their face, that you can't compare that to anything else. I have not seen anything else like that, more than that. So that is what makes us carry on to do all this, carry on to do such great things for our patients. And this is what the team looks at as well. The second patient story as well, again similar story of waiting community bed, a patient waiting community bed, staff constantly mobilizing them, getting them out of bed, positive encouragement, motivation, even with eating, drinking, managing themselves independently. And then we had to re-refer them to social care to downgrade them to a D2A1 pathway. Again, some of these things, pictures are there that show all the work that we have been doing. Some of them are just phone calls, some of them are cards, and that is what just stays with us. Not everything can be put onto a PowerPoint, but that is what it is, the huge positive impact. And again, all this because we have a brilliant team and the wider team that is so much focused on getting it right, because this is what is right for our patients. So yeah, thank you again for this opportunity, and I'll give it back to Karon.
Many thanks, Sam, and thank you, Sarah, for sharing some of the really good work you and the teams are doing across the QE. Obviously, Nick, we are continuing to work with other wards and other teams as well, and really building momentum up. And we just hope to see this growing and becoming bigger and better, because at the end of the day, the most important thing is that we're all here for our patients. So thank you for listening to the QE story.
Karon, Sam, Sarah, that was brilliant. Such great patient stories there that have come out of that. So you give some really great examples, and I think it is the simplicity again. It's the simple things that you do, that you can just take control yourself and give something a go. And I think that's the message. And then the other thing I picked up from you, Karon, is that this is just the start. You want this to become business as usual, and that's what we're trying to encourage with the games. The games just creates a vehicle to get things started, but this shouldn't stop at the end of May. This is just help things get things moving. So thank you very much for that story. Hopefully lots of inspirational messages. Keeping it simple, as somebody we know well says a lot. I'm going to open it up to the room now. Has anybody got any questions for Amit, Sam, Karon, or Sarah? Either put your hand up or drop it in the chat. Any queries? How did they do it? Any top tips, possibly? Anything from anybody? Lucy.
Hi, thank you so much. It's really inspirational presentations, Karon, Sam, and Amit, of course. I had a question for Sam, and that is, if you were speaking to an organisation that was really interested in getting involved but hadn't yet got involved, what would you say to them as to how to sort of get started and get moving?
Yeah, I just kind of briefly sort of mentioned it, in the presentation as well. But again, the key sort of idea would be, so we have to get involve the key stakeholders, involve your organization to actually, create it as a strategy that it has to come from top, be driven at the top. At that board level priority, to be then taken down to the level where actually patient care happens at the ward level. So having that clear strategy, at the top, and then enabling and supporting the middle level managers and ward level, managers to drive this sort of change. And even at our place, QEH, it has been Karon who has sort of helped drive this change. We've had at the QEH a team that meets every week. It is a collection of the MDT, who a task and finish group in a way, who meet every week, drive that bit of motivation, encouragement, share, and we almost share ideas every week, weekly feedback. So they are some of the tips, and I probably Karon might be able to elaborate. Of course, Karon McGuire, our Deputy Chief Nurse.
Thank you so much, Sam. That's really helpful.
Thanks, Sam. Yeah, Karon, did you want to come in? Karon McGuire.
Yes, thank you. I would just add, as an adjunct to that as well, Lucy, what we're going to do, what we're doing, but formalising going forward is including it in other strategies across the organisation. So patient experience strategy and work plan 23-24, we would, and some of the tangible outcome measures we would like to weave into the other organisational strategies. So I think that's also an important platform if you're struggling to get it off the ground. Make it work for you for other forums as well. As we've already spoken about, we're hoping to see a reduction in falls across the organisation, a reduction in length of stay. So, you know, link it with your UEC work and patient experience, and that's what we're doing. Our inpatient survey action plan, all of those things are integrally linked, because this is an overarching, isn't it? It's absolutely the right thing to do from a patient experience and outcome perspective, but it's about boxing clever and including it in at this time of year as we plan our 23-24 strategies across an organisation and within subspecialties. So that would also be what I would add to what Sam's already said.
Thanks, Karen. That's really helpful. About this becomes what we do around here. And I think Karen mentioned that as well. And I think touching on a point you made there, just to draw that out, any kind of measurement you can get to help you understand if that you are making a difference. Sometimes it's difficult with this because deconditioning is difficult to measure as a thing, but sometimes just about functional activities, you know, being up and about is sometimes helpful. And we know that it's starting to have an impact, but obviously sometimes very difficult to actually pinpoint exactly what you're doing. But if you can measure it, and I think Sam touched on this as well about how can you measure it, how can you get some kind of data that sits behind it to show that you are making a difference. So thank you for that, guys. I'll go to Giles, then I'll go to Claire.
Thanks, Nick. Question, I guess, for Amit, and it's around that piece where so I think there's a real lack of understanding in the pre-hospital environment around paramedics on the potential of starting a journey down deconditioning. And I know there's some work, a lot of work that we're doing around alternatives to ED, which is clearly where we want to start. But I guess, how do we raise the awareness within that first step of a potential deconditioning journey to really maximise our bang for our buck, I guess?
Thanks, Giles. I think you're absolutely spot on. I think traditionally what's been happening is hospitals and EDs have always been thought of as the right safe space. And more recently, I think more evidence, as we saw earlier on, has suggested that may not always be the right choice. With specific regards to the paramedic community ambulances, I think there is work ongoing in the background. Some of our own paramedic colleagues have been talked about. The slide set goes to them. We recently held a 1-hour training session for the Yorkshire ambulance services, telling them about the real life examples around frailty and deterioration. And if you are any of the people on this call want a similar session arranged for their own ambulance services, we're very happy to do something like that. One of our colleagues, Rob, has been instrumental with the College of Paramedics and has been writing some stuff around frailty, including the work around deconditioning. So there is a knowledge gap, there is a gap in understanding, but that is not just limited to a particular area or a particular group of professionals. I think we have work to do amongst the public, amongst the schools, amongst all variety of hospitals and social care staff to increase the understanding of this. And this is work in progress, but all help is very gratefully received and appreciated. So do keep in touch.
Thanks, Amit.
Thanks, Amit. And if I may, I'll tie in with Rob around the ambulance piece, because I think there's also a bit of education opportunity for the people that aren't transported to hospital, who could potentially next time be transported to hospital. So work on the reconditioning in the home.
Brilliant. Thanks, Giles. Claire.
Hi, I'm a quality matron at Shrewsbury and Telford Hospital. We're very much at the start of our journey with the reconditioning games and building momentum. But I just wondered, for those that have been doing it a little bit longer, in terms of your metrics, when did you start to see tangible results? Because that's the challenge that I'm getting now. So for me as a nurse, it's just the right thing to do, and the patient experience feedback to me is enough. But in terms of like a reduction in falls or pressure ulcers, when did you start to see that happen?
I'll jump in on there if that's okay. So straight away, really, when it comes to up and conditioning, recognising patients as soon as they're coming into your environment, that their mobility, nutrition, hydration are at risk. So we have some key policies in place that identify risk straight away, which means that we can then be proactive. Also with Zoe's point, this ties in how we motivate our staff, and also over Christmas, the challenges we had in acute care with our staffing. So it is basically utilising our time more efficiently, and also there are challenges with staffing, but if we have 6 patients in a day room and not in a bay, that member of staff is in the day room doing activities with our patients rather than watching them in bed. You know, for us, it's just a different way of working, which doesn't really feel like we're putting any more work on our staff. It's just a very, you know, it's coming away from the conditions, you know, that kind of learnt behaviour of we're watching patients sit outside their bed space. No, absolutely not. We have wonderful facilities here. We're using them and we're utilising the equipment that we have been gifted or have raised money for. And our patients are in just a different space, but being cared for in the same way. So there are challenges, but we are seeing results, especially with pressure areas and falls, really quickly. Patients are engaged, then they're not, that, you know, we're engaging with them as well. If they need the toilet, we're there, present and ready to go, rather than them trying to get up and falling. So we're seeing tangible results already.
Lovely, thank you.
Karon, did you want to jump in?
Yeah, sure. So Claire, just on your point about collecting data, etc., I won't deny that that's one of the most difficult parts of this, because it's really difficult to collect some tangible data around this. So the data that we've started to collect through our criteria to reside paperwork that we fill in every morning is who's up, who's dressed, and we've just added who's actually using the wash facilities on the ward. When it comes to your things like the reduction in falls and the reduction in pressure ulcers, we absolutely expect to see that reducing as we recondition patients and we stop deconditioning patients. I think, and Karon will not deny this either, I think in the very first part of all of this, we probably seen a slight increase in falls because we were getting more people out of bed and mobilising. But those falls have now turned into more sort of lowers to floors and slips rather than falls, and certainly we have seen a decrease in falls with any serious harm or any harm full stop, because we're actually encouraging people to be more mobile, and they're the real tangible things that we really want to see and the things that are really making a difference, because it's actually providing safer care for our patients.
Thanks, Karon. It's really, really helpful. Conscious of time, and I'm going to draw things to a close. So thank you, everybody, for joining us this afternoon. I have put the link in the chat to our Future NHS platform, so please do go and have a look at that. Remember, you can apply for medals for retrospective work that you've already started, and you've it's not just about new work. So please have a look at that and get the work that you're doing already, get it celebrated and recognised, and do those nice things about, you know, presenting to your staff and your teams and get the message out there. Really encourage people. Follow us on Twitter if you're on Twitter at Recon Games UK. Any other messages, please get in touch with us. Any queries, we're always here to help as much as we can. On the platform, you'll find the medals platform, pledge cards, lots of resources, videos, the good practice repository as well. there's a whole database of all the work that's happening at the moment. Go on there, get inspired, and start doing just those little small things. And I think all the work that Karon, Sam, and Sarah, I'm sure they would back us up. It just started small. It started somewhere, and then it built over time. That's the key message for me. Thank you very much for your time today. Next session is on the 9th of February with a keynote speaker yet to be announced. But please keep an eye out for that. But please do come back 1 o'clock on the 9th of February. But for today, thank you very much. Enjoy your afternoon and the rest of the week.